for New York City healthcare providers. Please note that you have been placed in listen-only mode, so if you have questions during the presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows at the end of the presentations. The slides from the webinar, as well as a recording of the event, will be made available on the provider page of our website by tomorrow afternoon. Additionally, we thank you for your participation in a very brief poll that we will issue at the end of the webinar today. Today, our discussion will center on COVID-19 and maternal health, as well as an update on Missy in New York City. And with that, I will hand it over to Dr. Dee Ray, Critical Care Planning Lead for the agency's outbreak response.
Great, thank you. Sorry, thank you, Allie. And can you advance the slide, please? So we just want to acknowledge today, I know we have a packed presentation, but we do want to acknowledge and celebrate Women's History Month. We're going to mention a few, I'm just mentioning a few pioneers in medicine and public health, and I encourage you to take a look at the slides after the presentation, and also to explore the inspiring lives of these women on your own. So the first is just Elizabeth Blackwell. She was the first woman to be granted an MD in the United States. Next, Rebecca Lee Crumpler. She was the first African American woman to be granted an MD. We don't have any images of her, but here's a photo of her book of medical discourses, which was published in 1833 and was one of the first medical publications by an African American. And finally, Jocelyn Elders, the first African American and second woman to serve as U.S. Surgeon General. And she remains a strong advocate for women's health, empowering people through health education. And she is an advocate for improving access to medical care, among other related causes. And can you advance the slide, please? So I think Allie went over our outline here. I'm going to very quickly go over recent epidemiology and updates on the guidance. We're going to have an excellent update on Missy and a very popular topic that we get a lot of questions on, COVID-19 in pregnancy. Please leave your questions in the chat and we will try to address them as a panel at the end. Please advance the slide, please. So the new developments and guidance. So, this slide is, as usual, an update of COVID worldwide. We are reaching, you can see that there was an extremely high dip that we're all very familiar with. There is kind of a leveling off of that. We unfortunately, though, are at over 121 million cases, over 2.6 million deaths. New cases are still rising in overall globally, and the Americas and Europe are major contributors to that, as you can see in the map below of global. But on the other hand, on a hopeful note, over 400 million vaccine doses have been administered worldwide, which is a 22% increase from last week. And can you advance the slide, please? So drilling down to the US, you can see that, again, there is a stability and a leveling off of cases in the US relative, especially to earlier this year. There are over 29.6 million cases. We have exceeded 500,000 deaths. The states with the highest case rate, as you can see in the map, indicated, or I'm sorry, that's not on the map, but the states with the highest case rate in the past week include, unfortunately, New York and also New Jersey. But as you can see on the map, the hopeful note is that about 12% of the population has been fully vaccinated. And you can see that in some states, the darker areas represent a higher percentage vaccinated. And can you advance the slide, please? So here in New York City, as we are at over 789,000 cases, over 25,000 confirmed deaths, as you can see on these graphs. But as you can also see on these graphs, over the past week, our cases, hospitalizations, and deaths have either stabilized or trended downward. As a reminder, that gray area at the end is data that are not complete yet. But even looking outside of that, everything is, everything is either trending downward or stabilized. Just a reminder, though, that the cases are still high. COVID-19 is still a big concern, even though we are moving in the right direction. And can you advance the slide, please? And of course, in New York City, vaccine administration continues apace as supply increases. Over 3 million doses have been administered. Almost a quarter of the adult New York City population has received at least one dose. And, we look forward to see this line going higher and higher in the coming weeks. And can you advance the slide, please? Just a quick update on respiratory protection and source control for healthcare personnel. We have a link on the slide for our New York City Health Advisory number 4 and CDC interim guidance that addresses this issue. But the guidance in short says that healthcare providers should use N95 respirators when caring for patients with suspected or confirmed COVID-19. This isn't exactly new, but just confirming that that as we, N95s are not in the short supply they were in earlier this year, all patients with suspected or confirmed COVID-19. And additionally, during periods of high COVID incidence, like I said, even though COVID rates and consequences have stabilized, we are still at a high incidence in New York City. So healthcare providers caring for patients not suspected of having COVID-19, so this is everybody, this is everybody all the time, should use eye protection. And if you have an aerosol generating procedure, even if the patient you don't suspect the patient has COVID-19, you should still wear that N95. And you can consider using N95s or a well-fitting face mask in all patient encounters, COVID or not. Of course, continue to practice universal source control. That means during breaks, even when you are not directly involved in patient care. And of course, even persons who have been fully vaccinated or who are fully immune need to take these steps. And can you advance the slide, please? Additionally, we have updated New York State quarantine recommendations. We had spoken at the last presentation about CDC recommendations. These have been adopted with New York State. And there are many facets of the recommendations for persons who are fully vaccinated. So the definition of fully vaccinated is greater than 2 weeks from completing a vaccine series. That means for a 2-dose series, you need to have 2 doses and it's 2 weeks later. For a 1-dose series like the Janssen vaccine, it's 1 week and then 2 weeks since completing the series, or 1 dose and then 2 weeks since completing the series, and less than 3 months have passed since completing vaccination. I know some healthcare providers who were vaccinated in December are coming up on that date. And so in New York State, fully vaccinated persons within that time window are not required to quarantine or get COVID-19 testing after domestic travel or exposure to COVID-19 if they remain asymptomatic. Additionally, persons who, so regardless of vaccine, if you have recovered from COVID-19, you are exempt from quarantine and testing after domestic travel or exposure if you remain asymptomatic and it is less than 3 months. So this is just showing that the natural immunity recommendations are consistent with the vaccine recommendations, and that 3 months for persons with natural immunity are from the development of symptoms or the first positive diagnostic test. This does apply to healthcare personnel, but of course, healthcare personnel do have to continue in any regular testing, any employer mandated testing, or you do have to get tested after an exposure or travel before caring for patients. And of course, any inpatients or residents in healthcare settings still have to quarantine given the possible risk to other patients. And can you advance the slide, please? Vaccine eligibility continues to be broadened in New York State. Recently, since our last presentation, eligibility has been expanded to those 60 to 64 years. Public-facing government and public employees not-for-profit workers who provide public-facing services to New Yorkers in need, and essential in-person public-facing building service workers. Just as a reminder, you do not have to write notes. The persons with underlying medical conditions do not need to obtain documentation from a provider. The patient may self-certify eligibility based on their underlying condition and don't need proof. So detailed up-to-date list of currently eligible groups, it's growing longer every day, is at nyc.gov/COVID vaccine distribution. And can you advance the slide, please? Just a couple of resources to remind you about. Our provider website, and we can copy these links in the chat if you would like. We have a special provider vaccine website, which is nyc.gov/health/COVID vaccine provider. And of course, our data page, which has a lot of interesting ways to explore COVID data in New York City. And advance the slide, please. And now I'd like to pass it off to my colleague, Dr. Lee, for a really exciting update on multisystem inflammatory syndrome in children.
Thanks so much, Dr. Ray. Just wanted to make sure that you can hear me.
Yes, we can hear you.
Excellent, thank you. Hi, everybody. Thank you so much for joining us this afternoon. And I'll be speaking about the epidemiology of multisystem inflammatory syndrome in children, or Misc, in New York City. Next slide, please. Misc is a new syndrome that was initially reported by clinicians in Europe in April 2020. And what they described was clusters of children who were presenting with an unusual acute febrile illness accompanied by cardiogenic shock and or features of Kawasaki disease. Now, almost a year later, many presume Misc to be a post-infectious inflammatory condition following SARS-CoV-2 infection. For many, this infection may have been asymptomatic. The presumption of the relationship with SARS-CoV-2 is supported by the fact that a sizable proportion of patients with Misc have had respiratory specimens that yield negative results upon testing for the virus. In addition, the peak of Misc cases has been seen about 4 to 6 weeks after the peak of COVID-19 cases in many areas. So listed here are the criteria for Misc as it's been defined by CDC. So these criteria include a febrile illness that involves at least 2 organ systems and elevated markers of inflammation in a hospitalized person less than 21 years of age. There should be no alternative diagnosis for that illness, and the criteria require either positive results for SARS-CoV-2 by nucleic acid amplification, by antigen testing, or serology, or you would need to have a positive COVID-19 exposure in the 4 weeks before illness onset. And as of March 1st of this year, over 2,600 cases meeting Misc criteria, along with 33 fatalities, have been reported to CDC from 48 states, DC, and Puerto Rico. Next slide, please. In early May 2020, we at the City Health Department started to request reports of possible Misc cases. And on this slide, you can see that we've received by now close to 500 reports in this past year. We investigate each report with a chart review, and of those that we've received, we have 291 who have met that CDC case definition. We had 175 that did not, and we do still have a number of reports that are still under investigation. Now, at the bottom of the slide, I've split those 291 cases that met Misc criteria into those occurring during what we'll call Wave 1 and Wave 2 of the COVID-19 pandemic here in New York City. Now, for the purpose of this presentation, Wave 1 is March through October 2020, and Wave 2 is November to the current period. Next slide, please. So here you can see an epi curve for those 291 cases by hospitalization date over this period of time. So I know that the x-axis is a little bit messy looking, but essentially what you can see is that there was a distinct peak in early to mid-April, early to mid-May of 2020, and then really very few cases over the summer and early fall months, and then a second peak really sort of clustering close to the beginning of February. Now, there often is a reporting delay with Missy cases, as well as a delay due to that case investigation that I was just describing that does involve a comprehensive chart review. And then there's a review of all those chart abstractions. So this means that we anticipate more cases will fill in this epicurve, and we anticipate those cases will fill in for January and February and clearly for March as well. But even if we consider all of those reports that are still pending investigation, it does seem possible that we may not see the same magnitude in the peak of cases as we had seen in that first wave back in May of 2020. Next slide, please. So in this next batch of slides, I will show you some of the demographic characteristics of Missy cases in New York City. Now, looking at borough of residence, for this 291 cases who met Missy criteria, you can see that children in the Bronx and Brooklyn each represented about a third of the Missy cases that have been reported to us, with Queens contributing about 19% of those cases. Manhattan represented 10% and Staten Island represented 3% of the cases. Next slide, please. If we look at the Missy cases by age, you can see here that most cases occurred among children and adolescents up to age 14, which is similar to what has been reported nationwide. Nationwide, the median age of Missy cases is 9 years of age. Importantly, I'll speak a little bit about what we are seeing with MIS outside of this age range a little bit later on in this presentation. Next slide, please. Slightly more than half of the reported cases, or 56%, occurred in male patients. Next slide, please. And looking at those same 291 cases over this past year, we can see that a third occurred among Black children, and another third occurred among Latino children. White children represented 12% of the cases, and Asian Pacific Islander children represented about 7% of the cases. The distribution of race ethnicity among Missy cases has definitely been a focus of attention for our team, as well as other investigators looking at Missy in the US and outside as well. And we investigated this further by using population-based data to provide a context for what we were seeing, because with these data, you can see the simple proportions represented by each racial ethnic group. But outside of the context of using population-based data, it's really hard to know how to interpret these data. So if you wouldn't mind going to the next slide, I have sort of a packed table here, so we'll take a little bit of time to focus on a few points. So for this, which actually was a manuscript that our team had developed, it was published late last year in JAMA Network Open. What we did was we used population data for New York City to calculate incidence rates for Missy, stratifying by race and ethnicity. And we also did this for COVID-19 hospitalizations, and I'll sort of walk you through this table. So that first column of Missy cases presents the raw numbers and proportion of all Missy cases. The next column to the right is the incidence rate for Missy cases. And then further to the right is the incidence rate ratio, where we looked at the incidence for each racial and ethnic group using the incidence for white children as our reference. If we go to the next column to the right, you can see the COVID-19 hospitalizations, and we used a similar model of presenting the raw numbers, the incidence rate for COVID-19 hospitalizations, that incidence rate ratio for COVID-19 hospitalizations. And then the last column furthest to the right is the New York City population data, again stratified by these racial ethnic categories. And again, this is all to try to sort of add context to what we were seeing for those proportions of cases. And if we can sort of look at each of these columns, you can see that, and first I'll mention that this was restricted actually to the months of March through June. So really the sort of highest peak of the wave 1 cases that we had seen. And you can see that the overall incidence for Missy was 11.38 cases per 100,000 population, restricting that to those under 20 years of age. We noted that Black children overall in New York City comprised 22% of that population, but represented 34% of our Misc cases, as I just mentioned in the previous slide. Latino children represent 36% of our New York City population, and comprised about 30% of our Misc cases. So, but now we add on the incidence rate ratio analysis, and the red box highlights the incidence rate ratio for Black compared to white children and Latino compared with white children. And we found that Black and Latino children did have a higher incidence of Misc when compared with white children. Black and Latino children also had a higher COVID-19 hospitalization rate compared with white children. We saw no difference in our analyses comparing Asian Pacific Islander children with white children, either for Misc or for COVID-19 hospitalizations. I will say that we had wanted to do this similar analyses looking at overall COVID-19 cases, so not just looking at Misc and not just looking at children who'd been hospitalized, but all those who had been diagnosed. But unfortunately, the data that were available had a lot of missing race ethnicity data for this particular age group. And in fact, I think more than 50% of cases did not have race ethnicity data. So we could not conduct these analyses looking at overall COVID-19 cases. But what we could say in summary was that our population-based data did indicate a disproportionate burden of Misc among Black and Latino children in New York City. It's unclear, though, whether this finding represents a phenomenon that's distinct from the increased burden of COVID-19 that we have certainly come to recognize in Black and Latino communities, because we saw that disproportionate burden also in COVID-19 hospitalizations in these same communities. So this is all to support the finding that there is a disproportionate burden that we have observed among Black and Latino children, even when you apply the population-based data. And I think there's a lot of work that's currently happening and needs to be done to be able to further explore this. And we will continue to look at this and hopefully have more complete race ethnicity data for all of our COVID-19 cases to conduct additional analyses in the future. Next slide, please. So I'm going to switch gears for a moment and just highlight the SARS-CoV-2 testing results for our full cohort of 291 Misc cases. So I'm now going back just to the whole number of cases that we've received in this past year. So among these cases, we can see here that 82% of our cases met Misc criteria with a positive lab result. And about half of those cases tested positive by serology only. Another 26% had both positive testing by serology and PCR, and 7% were positive by PCR alone. There is a proportion, 17%, that did not have a positive test result by either serology or PCR, but they did have an epilink to a COVID case. Next slide, please. Now, this slide summarizes some of the clinical findings for this cohort of 291 cases of Misc. The median interval between onset of fever and hospital admission was 4 days, and the median length of a hospital stay, and again, hospitalization and fever are requirements for these criteria. The median length of hospital admission was 5 days. The most common symptoms reported by patients meeting Misc criteria were predominantly gastrointestinal in nature, so vomiting, abdominal pain were seen in over 60% of all patients. Rash was seen in about half, as was conjunctivitis, and diarrhea was reported by almost half of all Misc patients. Next slide, please. You may have heard stories in the lay press recently about how cases of Misc reported by different settings, reported by different providers, have been more severe than what had been experienced during the first wave of COVID. So we actually tried to look at this by selecting characteristics in our data that might suggest higher acuity of illness. So things like receiving care in an intensive care unit, being mechanically ventilated, or having a diagnosis of shock and death. So the numbers are small, so this is very much preliminary, but this preliminary look did not support the notion that there were differences in disease severity for the more recent Missy cases. As you can see here, the proportion admitted to an ICU, who were ventilated, who were diagnosed with shock, were fairly similar. We did unfortunately have one death of a child who met Missy criteria, and that child died during the earlier wave of COVID-19. Again, there's a reporting delay from Missy, and there is a number of pending investigations, so it is possible that this picture may change with additional data. Yeah, the next slide, please. Last year, when we were calling hospitals in the city to ask if they'd seen cases of Missy, we started to hear about patients who were older than 21 but had a compatible presentation. And so this entity, which we're calling Misc, has been really challenging to investigate in adults for a number of reasons, including the higher prevalence of underlying conditions that may make it harder to see sort of a distinct entity. And at this time, there is no real standard case definition or criteria for Misc, but early on, we were in conversations with CDC about what we'd been seeing and hearing, and CDC independently had been receiving reports of similar cases from other parts of the country. And so we collaborated with CDC in these other areas to create this article for their weekly morbidity and mortality report to inform healthcare providers of this possible entity. It does seem that there is an entity that is fairly uncommon, but that does seem to have a similar presentation to MIS in children. Next slide, please. So I'm not going to spend any time on this, but just to let you know that there is a new diagnosis code for MIS, which can be applied for children and adults. Next slide, please. And I'll end here with a list of resources related to MIS-C. We do still have a reporting request for MIS-C cases. And last year collaborated with a team of pediatric providers to create guidance for the sort of evaluation or consideration of Missy in ambulatory care settings. So you can see the link there. And in addition to CDC's webpage, there is a good resource through the American College of Rheumatology regarding the clinical guidance for management of patients with Missy. And I'll end it there. Thank you so much.
Good afternoon, everyone. My name is Amita Marthi, and I am a clinical specialist within the Bureau of Maternal, Infant, and Reproductive Health as part of the New York City DOHMH. Next slide, please. So I'm going to briefly talk about the effects of COVID-19 on pregnancy and birth outcomes in infant health, touch on questions about vertical transmission, and finally end on COVID-19 vaccine questions. Next slide, please. So the current evidence about COVID-19 and pregnancy comes from a group within the CDC that does CDC surveillance. It's called PILOT, which stands for Pregnancy and Infant Linked Outcomes Team. And what they do is they look at a number of different databases and do surveillance specifically around incidence of COVID-19 and report on these pregnancy outcomes. They have released 2 reports so far. The first was last year in late October, and then an update on that released earlier this year. And you can see that they looked at 1.3 million cases in women who were aged 15 to 44 years or reproductive age, of which 35% of them were available for pregnancy status, and of which we see that 6% of those women were pregnant. Of those pregnant women, 6% of them counted for all symptomatic women with laboratory confirmed COVID-19. When you look at these women, you can see that the pregnant women who did have COVID-19 were more frequently Hispanic or Latina, as well as Black. When most common symptoms reported were cough, headache, muscle aches, and fever. However, it was noted that symptoms were reported less frequently by pregnant women than by non-pregnant women. Next slide, please. So this chart actually comes from the earlier report that was released late last year. And you can see here that pregnant women are 5 times as likely to have hospitalization, almost 2 times as likely to have an ICU admission, and more likely to have mechanical ventilation. Next slide, please. So this is the updated version. And again, you'll see that those ICU admissions, invasive ventilation, and the need for ECMO are still listed as being more frequent in women who are pregnant. There were 34 deaths reported amongst those 6% of women who were symptomatic. And when stratifying by race, you can see that ICU admissions are seen more in Black, Asian, and Hispanic women, and invasive ventilation was seen more in Native Hawaiian, Pacific Islander women, Asian women, and Hispanic women. Next slide, please. So I'm going to just turn a little bit and relate this to New York City maternal mortality ratios. And you can see here that, again, maternal mortality is distinctly and heavily borne by our women of color. Our highest rates are seen in Black and non-Latina women, followed by Asian Pacific Islanders, and lastly by Latina women. Next slide, please. So what are the thoughts that contribute to increased severity of COVID-19 during pregnancy? And some thoughts that were out there are that elevated risks may be related to some of the physiologic changes associated with pregnancy. These include a decreased lung capacity, but an increased heart rate and oxygen consumption, a shift away from cell-mediated immunity, and of course the increased risk for thromboembolic disease due to the hormonal milieu of pregnancy. Other risk factors that seem to worsen COVID-19 in pregnancy seem to be chronic diseases like obesity, high blood pressure, and gestational diabetes. Next slide, please. What you'll see here is a graph of severe maternal morbidity by chronic conditions. And you'll see that with the presence of one chronic disease, the rate of severe maternal morbidity increases drastically, and with any chronic disease is almost the same as having simply hypertension. Next slide, please. The limitations of the pilot data is basically the following: that the case information is limited or unavailable for a portion of those cases. Pregnancy status is missing, as well as data on race and ethnicity. Information on symptoms and underlying conditions is also missing, and also there may be some reporting bias due to observational data being collected through passive surveillance. Next slide, please. So what happens in mild infection? What we see here is one study that came out of Parkland Health in Texas between March and August of last year. And this population is heavily Latina, as you can see. 252 women tested positive for COVID-19 at some point during their pregnancy. Parkland Health was offering COVID-19 testing at all sites, including inpatient and outpatient locations, and at different times during the pregnancy. What they found was that most of their pregnant patients who were diagnosed with COVID-19 did not experience severe symptoms and were never hospitalized for COVID-19. These same patients who were not hospitalized for COVID-19 were not at increased risk for obstetric complications. So it seems to be that if a pregnant woman has severe disease, then she is more likely to encounter some severe morbidity from that disease. Next slide, please. So we're going to switch over a little bit to the Surveillance for Emerging Threats to Mothers and Babies Network, or SETNet. This is a slightly different kind of CDC surveillance, which looks at databases and information collected through surveillance for syphilis, surveillance for hepatitis C, and then have adapted that surveillance for COVID-19. SETNet actually started with the Zika pregnancy registry and has now continued to and has expanded to surveillance for COVID-19. Next slide, please. The information that they look at consists of 4 data sets. You have maternal data sets, which are vital records and case reports, birth records, case reports, investigations, infant follow-up, again, through early hearing detection and intervention, as well as other medical records and vital records, and then through laboratory reporting from the electronic system. Next slide, please. So SETNet did collect information on pregnancy and infant outcomes amongst 16 jurisdictions, and they found 5,000 women from March to October of last year, and data is only available for about 4,500 women. So where we have gestational age for 3,912 live births, 13% were preterm, which is higher than the national estimate of 10%. They have 610 infants that had reported SARS-CoV-2 test results, and perinatal infection was noted to be infrequent, and usually in those mothers where infection was identified within 1 week of delivery. Next slide, please. So the characteristics of those pregnant women with confirmed COVID-19 infection were that the median age was 28, 46% were Hispanic or Latina, and 45% had at least one underlying medical condition, of which obesity is the most commonly one reported. 84% had infection identified in the third trimester, and symptom status was known for 61% of them, of which 14% were reported to not have symptoms. Next slide, please. This is the table from that report, and you can see that for the most part, when you look at delivery type, 2/3 were for vaginal delivery, approximately a third was C-section. Of those C-sections, a third were emergent. Next slide, please. This table looks at the pregnancy outcome and gestational age amongst the live births. You'll see that it is a little small, I know, and I have the information on the next slide, but you have 13% of the symptomatic women delivering at preterm, and the majority do deliver at term. Next slide, please. So a third of the infants, so when we look at the infants, we have a third of them who have no test results. Of the remaining infants that we have test results for, 3% were positive. And again, this was, most of them were in women with infection identified less than 14 days before delivery. And there were no infections in infants with women with documented infection more than 14 days before delivery. Next slide, please. So we have, almost all of them were live births with small percentages of pregnancy losses at less than 20 weeks of gestation and a small percent at over 20 weeks gestation. Again, looking at gestational age, you have 13% of them delivering preterm, which was 4% at less than 34 weeks and 9% at 34 to 37 weeks or late preterm. 9% of the term infants were admitted to the ICU, but we don't have any data around the reason for admission to the ICU. And then we have 9 in-hospital neonatal deaths reported. Next slide, please. So now returning to the question of vertical transmission of immunity. As I will state later in the presentation, vertical transmission of infection seems to be rare, as we can see from the SETNet data. But what about immunity? So these are blood samples from 1,500 women that were analyzed, and of these, 83 had tested positive for antibodies to the SARS-CoV-2 virus at the time of delivery. So this is blood tested from the cord blood. I'm sorry, that's the mother's antibodies were tested, and then they looked at cord blood from 72 of these 83 babies, and they had positive IgG, with, for the most part, the quantity of the antibodies in the cord blood being correlated with concentration of IgG in the maternal blood. And it seemed to be that more time that passed between infection and delivery correlated to a greater number of antibodies. And antibodies were transferred whether the infection was symptomatic or asymptomatic. There were 11 infants whose cord blood was negative for antibodies. And it was found to have relatively low levels of IgG or IgM, which suggests that it was either early maternal infection or insufficient time for antibody production and transfer. Next slide, please. So treatment for COVID-19 during pregnancy, what we see is that the studies evaluating medications used to treat COVID-19 did exclude pregnant, postpartum, and lactating women. However, it is possible, to extrapolate data from studies of similar treatments, for example, highly active antiretroviral treatment for HIV or monoclonal antibody treatment for multiple sclerosis, which do demonstrate safety during pregnancy. So we may be able to extrapolate from those studies and presume safety for similar treatments for COVID-19. The FDA has stated that monoclonal antibody treatment should not be withheld from pregnant people who meet criteria for treatment with monoclonal antibodies. Next slide, please. So during the height of the pandemic, many hospitals limited visitation for pregnant and delivering people. And in fact, there was, a time when many pregnant people had to deliver alone, where they had no visitors except for the hospital staff for intrapartum management. Therefore, New York State put out a number of executive orders, with the most recent executive order dated and released on December 21st, that allows patients at least one support person and one doula. And the reason being for highlighting one support person and one doula is that some hospitals conflated a support person and the doula being the same, limited to the same one person. Responsibilities for the birthing facility include admitting the doula for the duration of the inpatient hospital stay, meaning admitting them to allow to be with the patient, to provide PPE for the doula, to not require proof of certification or training. If in-person doula support could not be provided, then to at least support virtual doula support with use of a secure Wi-Fi network, allowing personal cell phone or other device use. And then to post information on the visitation policy, including doulas, on the facility's website, and if possible, in the hospital itself. Our health department within New York City will be working to share best practices for operationalizing that state policy. Next slide, please. The benefits of doula support during birthing during COVID-19 can help with lowering rates of pain medication, C-section, and postpartum depression, higher rates of breastfeeding and satisfaction with birth, overall a shorter labor, and higher APGAR scores. This is especially important during that ever-changing environment of the COVID-19 pandemic. Many doulas do offer virtual support to clients, and both virtual and in-person support are excellent options, and many doulas have been vaccinated and have returned to in-person support. Next slide, please. So to switch gears to COVID-19 and breastfeeding, samples of breast milk have tested positive for the virus by PCR. Current evidence does suggest that breast milk is not a likely route for transmission. However, testing for viable and infective virus has not been routinely performed. What we can see is that the rate of infection between mother and baby is no greater when the baby is breastfed or remains with the mother, i.e. rooming in, versus being separated. Breast milk is the optimal source of nutrition for most infants, including those born to mothers with suspected or confirmed COVID-19. And pregnant patients or now delivered patients can take precautions to avoid spreading the virus to the infant. And they are listed in the linked CDC guidance as well as in our own guidance. Next slide, please. So what about antibodies in breast milk? There's a group of scientists working out of Mount Sinai who work with donated breast milk, looking at answering a number of different questions. And what they had was 15 samples of breast milk donated, 8 of which were found to be SARS-CoV-2 positive via PCR, and 7 from those people who were suspected to have the infection. They compared these samples to other donated samples from different women, which were donated before the pandemic started. All of the samples from the women who had recovered from COVID-19 were found to have binding to the virus, whereas the pre-pandemic samples had low levels of non-specific activity. They then tested the antibodies' response to the receptor binding domain of the spike protein, and 12 out of the 15 samples did show significant binding activity. Next slide, please. And now finally, we're moving to COVID-19 vaccines and pregnancy. People who are pregnant or lactating may choose to be vaccinated. Both the Society for Maternal Fetal Medicine as well as ACOG recommend that pregnant people do have access to COVID-19 vaccines. They should not be withheld from them. Nor should they be withheld from people who are lactating. However, we do recommend that each person talk to their provider or midwife about their choice and what those potential risks might be to themselves or to the fetus. Next slide, please. So both the CDC and FDA have safety monitoring systems in place to obtain information about vaccination during pregnancy. There are clinical trials either underway or planned to study the efficacy and safety of the COVID-19 vaccine in pregnant people. We are asking that all providers encourage their patients to enroll in vSafe, the CDC's voluntary smartphone-based app, which has a pregnancy registry to collect information on the health of pregnant people who get vaccinated. Next slide, please. What we have seen in vSafe is that substantial numbers of persons have self-reported pregnancy. There have been no unexpected pregnancy or infant outcomes related to COVID-19 vaccination. We do know that fever is a possible side effect from the vaccine, as well as the fact that persistently high fever during the first trimester might increase the risk for fetal anomalies or miscarriage. Therefore, those people who choose to get vaccinated can use acetaminophen or Tylenol if they were to develop a fever after vaccination. Next slide, please. We do have one case report that documents detection of IgG in cord blood after delivery in a baby after the mom received vaccination at 39 weeks of pregnancy. This is consistent with data of other vaccinations during pregnancy. Vaccines for influenza and Tdap are routinely recommended in pregnancy. And the reason being is that maternal antibodies are transferred to the fetus and can protect infants during those first few months of life while they're too young to be vaccinated. So while we only have one case report documenting this detection, it is possible that that protection may be there for COVID-19. Next slide, please. This is a screenshot of New York City DOHMH's website for COVID-19 and pregnancy. We do have a lot of these guidance documents posted there, links. We have some other documents and lots of information about doula training and doula information, as well as breastfeeding information and infant provisions. So next slide, please. That's the end of my talk. Thank you very much.
Thanks so much, especially to Dr. Lee and Dr. Murthy. We have a few questions in the chat, which I will get to. For the first one, maybe Dr. Foote can help us. And can you just discuss the New York State's guidance around, the people who have been vaccinated more than 3 months ago do have to quarantine and aren't eligible for the exemptions from quarantine?
Yeah, thanks. We were not privy to the conversations around that decision making, but I can venture some speculation. So the CDC had initially stipulated the same thing, that after 90 days to kind of go back to the non-vaccinated recommendations, but they have since removed that. But the state very recently just put out that guidance, and I think it was originally intended to align with the CDC, and they may end up updating it sometime soon, but I can't verify that. However, my guess is that it's more on the side of caution. It's not based on any current evidence that we have that there's a magical shut off of immunity at 90 days. I think it's more a conservative approach based on, we don't have a great understanding of durability of immunity yet. And I think also just a significant concern about the emerging variants in New York. But I will say, recent data that came out as recent as this week have shown that natural immunity is, it's pretty durable for at least 6 months. And so the thought is that vaccine-induced immunity is probably even more consistent than that. So we're getting better data to support more of a 6-month timeline. So there may be some updates in the future to that.
And Dr. Fritz, while we have you, can you just talk about, are any of the vaccines, are all of the vaccines still effective against the variants that we know about in New York City?
The short answer is yes, as far as we know. I think there has been kind of the bigger concerns in New York City are the B117 variant, which is otherwise known as the UK variant, and all the known vaccines are effective against that from what we've seen so far. We have a little less certainty or data about the new emerging variant from New York, the B1526. So that is being closely studied and monitored for any kind of vaccine breakthrough infections to do the sequencing to see if there's any relation with this variant, any difference with this variant versus wild type. So more to come. These are very early days of our understanding of the epidemiology of these.
And just very, very quickly, we have, once we talk about variants, we get a bunch of questions about variants. So Dr. Foote, can you just speak to the naming of the variants very quickly?
All I know about that, just in terms of the alphanumeric soups, all I can say is there is the international database that apparently has a hand in randomly naming variants based on their lineage. That's about as best. You've reached the limits of my knowledge on that topic.
I think I'll just add that, the naming the viruses for the places they were discovered. I know that, in the variant that we discovered in New York City, I was on a talk and I heard somebody call it the variant that started in Columbia University. So there's a danger in referring to variants as from the places they were discovered. Dr. Murthy, I don't know if we have any data on this, but do we know anything about variants in pregnancy?
Nothing as of yet. I'm sure people are working on it, but I haven't been able to find anything as of right now.
Great. Well, we will keep updated. We'll keep all of you updated on that as we learn more. And I think we're going to switch a little bit to another question that I'm not sure we have any data on, but we're getting a lot of questions on factors that are correlated with Misc prevalence or severity. I know you talked about race as one of those factors, but we had a question about obesity and Misc, especially since obesity is a risk for severe disease in adult COVID. Then we additionally had a question, I think, pertinent to the study that came out about race and vitamin D recently about vitamin D and Misc. And I'm just going to lump the last one in there, and you can speak to whatever we know, whether it's these factors or not, but viral load and Misc.
Okay, this is Ellen Lee, and I can try to tackle those different questions. I didn't have a chance to go through the kind of underlying conditions for the children who met Missy criteria, but we do know that about 70% had no underlying conditions, so were previously known to be healthy children, and the remaining 30% did have an underlying condition, and of those, about half had asthma. About 30% had obesity, and then the remaining had a smattering of other conditions. So again, 70% were previously healthy children. So this was I don't think that we have enough data yet to really look at sort of potential risk factors for Misc. We are, at the health department, don't have any data about vitamin D, but certainly there may be additional work that other investigators are doing related to vitamin D levels. I think that the question of viral load is a difficult one in that for these cases, as I think I mentioned previously, a handful are positive by nucleic acid amplification, but the remainder are mostly positive by serology. So at the time of diagnosis, we don't have an isolate. We're not able to isolate the virus from these children. So I think we can't really discuss viral load. And for many of them, they had either an asymptomatic or a polysymptomatic SARS-CoV-2 infection. So I know that questions have come up about the variant and various variants in Misc, but both for viral load and for variants, it's a question of our limited capacity to actually isolate virus from these children, because as a presumed post-infectious phenomenon, we just don't actually have virus to isolate. And I think that I do feel like the conversation when it comes to race ethnicity definitely has to be nuanced here, because although, as I had mentioned, we did note a sort of disproportionate burden among certain communities of color, I think we need to be able to evaluate that in the context of what did we see in COVID-19 cases in those same communities. And that's sort of the missing component of the analysis that I think is really critical to be able to make other conclusions about these data. So I do want to highlight that we can't say that there is an excess burden of Misc among these communities because we are missing that component of the data.
Thank you so much, Dr. Lee. And then we have another question about children. I don't know if whoever wants to answer can answer, but do we have an update on vaccines in children?
Is the question about when children will be eligible for vaccination, or when studies are including children? Is there maybe more to the question?
I think any information you have.
I'm not sure if anybody else has a bit more. There certainly are additional trials that have lower age ranges for vaccine trials. I want to say that the lowest age that I've seen so far for enrollment was age 12, but I certainly would defer to anybody else who may have more about this.
I think that's.
I heard that Moderna was opening to children younger than that, but is not fully there yet.
Great. And then as we get more results from these ongoing studies, and as we get more information, we'll update you on this webinar. And okay, in our last 2 minutes, maybe Dr. Foote can just talk to us about antibodies and antibody testing after people are fully vaccinated.
Sorry, and one more thing. This is Ellen Lee. I can say that I just looked up that Moderna does have a trial for kids ages 6 months and up. So it does seem that things are moving in the direction of lowering the age eligibility for these vaccine trials.
Thanks so much, Dr. Lee. Dr. Foote, do you want to speak to antibody tests after full vaccination? Okay, well, I can just say that, so, you know, the vaccines really work through having the body recognize the spike protein. And so not every antibody test will turn positive after the vaccine because different antibody tests test different pieces, antibodies to different pieces or epitopes of the virus. The other thing is that even if, you know, there are particular antibody tests, which I don't remember the name of right now, but those, even the antibody tests that do look at the spike protein and would become positive after vaccination, we haven't established thresholds at this point to determine, you know, what level of antibodies or what titers of antibodies count as immune versus not immune, or imply effectiveness of the vaccine versus not effectiveness. So at this moment, you know, if you have a negative antibody test, the short answer is that does not mean that your vaccine didn't work or that you didn't develop immunity. It's something that we're learning more and more about. I'd say in addition, you know, antibodies only reflect one portion of the immunity that we have against viruses. There is also cell-mediated immunity, which is pretty powerful, and it is a little bit harder to test than just an antibody titer. So as we progress toward a potential test for immunity from the vaccine, or you know, a reliable decision-making test against any sort of immunity, then we will keep you updated on that, and we'll let you know. At this point, it's past 2 o'clock. So just a reminder that the slides will be available probably by tomorrow on our provider website under the webinar section. Thank you so much for attending. And Allie, do you know when our next webinar will be?
Hi, Dr. Ray. Yes, our next webinar will be in 4 weeks. So we're moving to a monthly schedule. And it will be on Friday, April 16th. So the link to sign up for that will be posted on our webpage by the end of the day. And we hope that everyone will be able to join us in 4 weeks.
Thanks, everyone.